Dental infection, a lurking danger. I'm Dr. Gargi Mukherjee, an associate professor here at the University of Texas School of Dentistry at Houston. I work for the Department of General Practice and Dental Public Health. Disclosure. Neither I nor members of my immediate family have any financial relationship with commercial entities that may be relevant to this presentation. At any time while viewing the video streaming course, you can take a break by simply pausing your computer. At the completion of this course, you will receive instructions regarding taking the exam, which is necessary to complete the requirements for streaming video courses. Course description. This course is designed to review the pathways of oral infections as well as their link to systemic diseases. The diagnosis and management of these serious infections, such as Ludwig's angina and cavernous sinus thrombosis, will also be discussed. Methods on the prevention of the oral spread of infection in a clinical setting will also be presented. Course objectives. Upon completion of this course, participants should be able to describe the various pathways for dental infections. They will also learn to understand how to prevent the oral spread of infection in a clinical setting. In addition, participants should be able to recognize the signs as well as symptoms of serious disease, including Ludwig's angina and cavernous sinus thrombosis. And finally, participants should be able to understand how to manage and treat serious complications that may arise from an oral infection. Dental infections in the news. The following slide basically shows a few newspaper headings of serious dental infections which were present in the news. The first one says, brain abscess secondary to a dental infection in an 11-year-old child. The next title says, man dies from a toothache, couldn't afford meds. Another title, unemployed man with no health insurance dies after minor tooth infection spreads to the brain. And finally, woman died after tooth infection, according to the inquest. Toothache leads to a boy's death. This is an ABC News story from 2007. A simple toothache can be fatal. That is the sobering message of a 12-year-old Maryland boy left when, after his dental problems went untreated, he succumbed to a serious brain infection. Now we will talk about brain infections. Brain infections are rare, but can be serious and life-threatening. Patients with brain infections may present with malaise, fever, nausea, vomiting, changes in speech, seizures, neck stiffness, etc. Brain abscess in an 11-year-old child. An 11-year-old boy presented to the emergency room with a 2-week dull headache and 1 week of nausea and vomiting. He was then released with the diagnosis of flu/migraines and was advised to get bed rest. The next day, the child presented to the emergency room after his mom found the child on the floor screaming and holding his head. The child could not speak properly and was in a state of confusion. Magnetic resonance imaging tests confirmed a large lesion in the left temporal lobe. The patient was given a drug regimen of multiple drugs, including vancomycin, steroids, mannitol, and other antibiotics. The child was then transferred to another hospital facility. The child was awake, alert, and oriented, but had a challenge speaking normally. He had a prior toothache 3 weeks before, as well as swelling. However, the swelling ruptured and the pain then decreased. The child underwent neurosurgery procedures and a craniotomy. The child did present with some seizures and was given the drug phenytoin. His clinical dental examination showed gross decay of the lower left second primary molar. The tooth was then extracted and cultures were taken. A few days later, another temporoparietal infection was noted on the left side, and a second craniotomy was done. Brain abscess recurrence may occur within 2 weeks of treatment. The microbial tests confirmed the presence of Streptococcus aeruginosus, which is present in saliva as well as dental plaque. Streptococcus aeruginosus has been linked to purulent abscesses and has a high resistance to phagocytosis by leukocytes. It is presumed that the pathogen entered the vascular system and then spread to the brain tissue. The child's tooth had evidence of furcation involvement and a radiolucent lesion on the film. Multiple other tests were conducted to rule out sinus infection, ear infection, respiratory disease, or cardiac-related issues. The child's neurological status did improve after the second craniotomy, but the child still had challenges with comprehension post-surgery. He had proper follow-up and imaging tests and was prescribed the drug levetiracetam. Now we will talk about oral infections and their link to systemic diseases. For example, oral infections may affect the cardiovascular system. This may present as endocarditis or coronary heart disease. In addition, oral infections may even affect the lungs or the pulmonary system, resulting in bacterial pneumonia. Osteomyelitis may also be linked to systemic diseases due to oral infections. In pregnancy, there's an association between oral infections and the link to systemic diseases in which the child may have a low birth weight or the patient may have preeclampsia. And as we all know, diabetes mellitus may be linked to oral infections as well. Crohn's disease is another disease that has a link to oral infections. There are various ways to get secondary disease from a dental infection, including: number 1, metastatic infection. In this pathway of metastatic infection, the oral microorganisms travel to distant sites via the bloodstream. Another pathway may be metastatic injury. Metastatic injury occurs when oral microorganisms generate toxins which cause injury. For example, endotoxins, or LPS, which stands for lipopolysaccharide, and lethal exotoxins are excreted. And finally, a third way includes metastatic inflammation. In the pathway of metastatic inflammation, there is immunological injury from oral pathogens. For example, soluble antigens in the blood react with antibodies and form macromolecular complexes, causing acute or chronic inflammation. We will now discuss pathway number 1 a little bit more in detail. As you may recall, pathway 1 was metastatic infection. In the head and neck area, this may include brain abscesses, cavernous sinus thrombosis, orbital cellulitis, Ludwig's angina, and sinusitis. In the thorax region, metastatic infection may include infective endocarditis, bacterial myocarditis, and finally, a lung abscess or infection. In addition, metastatic infection may affect the bones and joints, resulting in osteomyelitis, which is bone marrow inflammation. This occurs more commonly in the mandible due to the thick cortical plate and decreased vascularization. And finally, as we all know, prosthetic joint infections may occur due to oral pathogens. In pathway number 2, we will now discuss metastatic injury. This may include stroke, heart attack, chronic meningitis, idiopathic trigeminal neuralgia, abnormal pregnancy outcomes, as well as a constant fever. And finally, metastatic inflammation, which is pathway number 3. This may include Behçet syndrome, which is a rare systemic vasculitis, or Crohn's disease, which is an inflammatory bowel disease, as well as chronic hives. As we all know, dental procedures or trauma may be associated with the spread of infection throughout the body. Some of these procedures may include dental extractions, as well as periodontal scaling and root planing. In addition, needle track injuries, for example, the posterior superior alveolar nerve block, may cause an infection to the pterygoid plexus. And as we all know, soft tissue manipulation during periodontal surgery or other procedures may also spread infection. And finally, root canal therapy. There are various bacteria that can cause caries, periodontal disease, cellulitis, and dental abscesses. The body's reaction to either prior infection or a foreign body reaction results in the formation of an abscess. Often, the tissue in proximity to the abscess undergoes necrosis. This then creates a passageway or fistula that drains the pus to the skin surface. Types of pathogens. There are numerous types of pathogens that can affect oral infection. Some of these include aerobic bacteria, anaerobic bacteria, facultative anaerobes, as well as fungi. Bacterial and viral pathogens colonize and then multiply, and then invade host tissues. The bacteria produce endotoxins, exotoxins, and tissue-damaging enzymes, which can target leukocytes. The oral bacteria found in periodontal disease and dental caries have been noted in the synovial fluid in rheumatoid arthritis patients, as well as patients with sepsis, obese patients, COPD patients, and kidney patients. These oral pathogens have been identified using tests including the Western blot and ELISA, which stands for Enzyme-Linked Immunoabsorbent Assay. These tests have identified oral flora in arterial walls, the valves of the heart, and aneurysms. Actinomycosis is a rare infection which causes organisms to act like parasites and resist phagocytosis and may cause fistula formation. Some studies show that periodontal therapy has caused a decrease in interleukin-6 and C-reactive protein, which are markers for cardiovascular disease. This decrease has led to improvements in endothelial function and arterial tissue elasticity. Some of the biomarkers of systemic inflammation include C-reactive protein, interleukin-6, tumor necrosis factor alpha, and matrix metalloproteinase number 9. Now we will discuss the spread of an oral infection. Oral infection can spread in many ways. Some of these ways include the blood, paranasal sinuses, lymphatic tissue, as well as spaces. Spread through the blood. Oral pathogens travel through the bloodstream, causing bacteremia, and may affect heart tissue. Oral pathogens may also travel by way of an infected blood clot. Oral pathogens may affect prosthetic joint replacements or artificial heart valves. We will now discuss the sinuses in the head. Ethmoid sinus, maxillary sinus, sphenoid sinus, and the frontal sinus. There are 4 sinuses in the head. These include the ethmoid sinus, maxillary sinus, sphenoid sinus, and the frontal sinus. As you can see in the drawing, the frontal sinus is the most superior sinus. Beneath it are the ethmoid sinus as well as sphenoid sinus. And finally, as we all know, we have the large maxillary sinus. Here's another drawing, once again, that shows the sinuses once again. The sinuses are all linked. The frontal, ethmoid, sphenoid, and maxillary sinuses open into the nasal cavity. They are part of the respiratory system, and they are lined by cilia as well as mucus. The sinuses are hollow and filled with air. This aids in the production of sounds by being resonance chambers. Oral infection can spread through the air sinuses. Sinus infection can travel through the nasal cavity to other sinuses. These microbes can then travel to the cranium and the brain. The maxillary sinus is most often affected due to the maxillary posterior teeth. Clinicians may see radiographs, which then may show opacity and thickening of the sinus walls and even perforation. Signs and symptoms of a sinus infection may include headache, a foul-smelling odor of the nasal or pharyngeal discharge, as well as fever, malaise, dyspnea, and pain due to inflammation. The oral spread of infection may also occur through veins. Veins of the face, especially in the danger triangle, communicate with veins of the brain. It is commonly believed that these veins have no valves, and therefore blood can flow into and out of the cranium. However, 75% of people actually have valves, and it is the direction of blood flow that allows the spread of infection and not necessarily the absence of valves. Serious complications resulting in an infection from the danger triangle to the brain may occur due to an external facial injury, facial lacerations or trauma, or from popping a pimple or boil. The facial vein may have valves in some individuals. Blood can flow in both directions. Here's an image of the danger triangle of the face. As you can see, this area includes the region right between the eyes down to the upper lip, including the nose. Here is another image of the danger triangle of the face. Thrombophlebitis of the facial vein occurs when a blood clot travels to the cavernous sinus and forms a cavernous sinus thrombosis and then spreads to the dural venous sinuses. This consists of multiple sinus cavities. Next, we will talk about the oral spread of infection through the lymphatic tissue. Dental infections can spread through the lymph nodes in the head and neck region. The lymph node may also increase in size and become firm to palpation when this occurs. Here's a nice diagram depicting the various lymph nodes in the head and neck region. Some of these lymph nodes are mentioned in the diagram, including the posterior auricular lymph nodes, the occipital lymph nodes, the parotid and preauricular lymph nodes. We also have the tonsillar lymph nodes, the submental lymph nodes, submandibular lymph nodes, the supraclavicular lymph nodes, the posterior cervical lymph nodes, and the deep cervical lymph nodes. As one does a proper head and neck exam, some of these lymph nodes can be palpated, and clinicians need to recognize for firmness of some of these lymph nodes, which may be a sign of a possible infection in the head and neck area. The lymphatic system. The retropharyngeal nodes are located behind the throat. These are the ones that are often involved in throat infections. We also have the submental nodes, which are located under the chin. During this clinical head and neck exam, one should really palpate for the submandibular nodes as well. These are located near the angle of the mandible. In addition, we also have the upper deep cervical nodes and the lower deep cervical nodes, which are located 2 inches above the clavicle. The submental nodes drain the mandibular incisors, which then lead to the submandibular nodes, which drain most of the teeth, which then drain to the superior deep cervical nodes or directly into the jugular trunk and vascular system. Pathogens can also travel through spaces in the head and neck region and cause infection. These oral microbes travel through fascial planes from one space to another and may cause a diffuse inflammation of soft tissue spaces. Cellulitis may occur. In cellulitis, there is usually a massive, firm swelling, presenting often with pain, tenderness, erythema, and diffuse edema. Here's a diagram of some of the fascial spaces seen as a transverse section cut at an oblique angle. There are numerous fascial spaces that are described in the diagram. The maxillary teeth often affect the maxillary vestibular space, buccal space, and canine space. On the other hand, the mandibular teeth often affect the mandibular vestibular space, buccal space, submental space, sublingual space, submandibular space, and space of the body of the mandible. Other spaces may include the sinus space, nasal cavity, and palatal spaces. Please note, many of these spaces are described in the diagram in the previous slide. The next slide shows the pathway of the spread for a buccal space infection. As you can see, the patient has a large left-sided swelling, and this is due to infection in the buccal space. The following slide describes a canine space / infraorbital space infection. Upon clinical evaluation, according to the slide, the patient is showing swelling lateral to the nose, obliterating the nasolabial fold. This is very important and critical. In addition, there is grouping at the corner of the mouth and swelling of the upper lip. And edema sometimes will also occur in the upper and lower eyelids, which then may close the eye. Clinicians must be observant of all these types of space infections, which may result due to a dental tooth infection. So what should clinicians look for as signs and symptoms of infection? Well, first of all, patients may show some redness or erythema. There's usually swelling associated with the infection. The infections may also create a sense of warmth to the touch. Some patients do experience pain with the infection, and there is often decreased function of that area during an infection as well. Signs and symptoms of serious infection are described below. For example, often infection progresses rapidly. Clinicians may find it difficult to palpate the borders of the mandible when there's an infection. Clinically, patients may also have an elevation of the floor of the mouth. They may experience difficulty swallowing as well as difficulty speaking. Some patients do present with a high fever, as well as trismus or limited jaw opening or movement. In addition, there are some individuals who just present with a toxic appearance or a septic individual. The cavernous sinus sits on the sphenoid bone. The internal carotid artery and a few of the cranial nerves travel through it. The pituitary gland sits between the two cavernous sinuses. The cavernous sinus is the only anatomic location in the body in which an artery completely travels through a venous structure. On the diagram on this slide, you can see the cavernous sinus as well as all the critical important structures that run through it, including multiple nerves. The cavernous sinus may be involved in the potential lethal spread of dental microbes. It communicates with the pterygoid plexus and superior ophthalmic vein, which itself anastomoses with the facial vein and emissary veins. The cavernous sinus receives blood from the superior and inferior ophthalmic veins, the superficial cortical veins, the sphenoparietal sinus, and the superficial middle cerebral veins. It is connected to the basilar plexus of veins in the posterior region. The cavernous sinus contains the internal carotid artery, as well as numerous nerves. These nerves include cranial nerves 3, which is the oculomotor nerve, cranial nerve number 4, which is the trochlear nerve, cranial nerve number 5, the ophthalmic branch and maxillary branch of the trigeminal nerve, as well as cranial nerve number 6, the abducens nerve. Once again, in this diagram on this slide, one can see some of these important structures that run through the cavernous sinus, including the internal carotid artery and multiple nerves, such as the oculomotor nerve, trochlear nerve, ophthalmic nerve, abducens nerve, and maxillary nerve. The cavernous sinus drains by two channels. It drains by the superior and inferior petrosal sinuses into the internal jugular vein via the sigmoid sinus. It also drains via the emissary veins through the foramina of the skull. The teeth are drained by the posterior, superior, and inferior alveolar veins. The lips are drained by the superior and inferior labial veins. Infections can cause thrombus formation. These thrombi can travel to the cavernous sinus via the veins of the face, resulting in cavernous sinus thrombosis. A complete lesion of the cavernous sinus may cause total ophthalmoplegia by affecting cranial nerves number 3, 4, and 6. Clinically, one may see a fixed, dilated pupil in cavernous sinus syndrome. Ophthalmoplegia is a paralysis or weakness of one or more of the muscles that control eye movement. As one can see in this picture, the patient's eye looks slightly swollen, as well as if you look at the left side, you can see it's not very symmetrical with the right side. There's also a reddening in the eye. In this slide, one can see, definitely not symmetrical eyelids or the pupil. And these are all signs and symptoms of possible cavernous sinus syndrome in a patient. The pupil is definitely fixed and dilated in these images. The causes of cavernous sinus syndrome may include metastatic neoplasms, pituitary tumors, aseptic thrombosis, intracavernous carotid artery aneurysms, carotid cavernous fistulas, bacterial or fungal infections, as well as idiopathic granulomatous disease such as Tolosa-Hunt syndrome, etc. Horner syndrome may also occur due to carotid ocular sympathetics. As one can see in this picture, there's a spread of infection to the cavernous sinus. The nerves affected once again include 3, 4, V1, V2, and 6, as well as sympathetic fibers to the orbital area. In cavernous sinus thrombosis, what occurs is there's a blood clot at the base of the brain which drains deoxygenated blood from the brain and takes it back to the heart. This can be fatal. Signs and symptoms include ptosis, headache, proptosis, nerve paralysis, tachycardia, fever, edema, photophobia, chemosis, drowsiness, as well as vision loss. The loss of function of the abducens nerve may cause nerve paralysis. Therefore, the eyeball cannot move laterally, and double vision, edema, and exophthalmos may occur. This can also result in blindness and hemiparesis. The microbes involved include Staphylococcus aureus, about 70% of the time, and Streptococcus. Other microbes include Haemophilus influenzae, anaerobes, gram-negative rods, as well as Aspergillus fumigatus and mucormycosis may also be involved, but rarely. So what is the treatment for cavernous sinus thrombosis? Usually, these patients are seen in the hospital setting or the oral surgery center. Broad-spectrum IV antibiotics, including vancomycin, ceftriaxone, and metronidazole, may be needed for 3 to 4 weeks. In addition, surgical drainage and sinus surgery may be needed. Many clinicians still use anticoagulants as well as corticosteroids. However, their indications are uncertain. Now we will discuss Ludwig's angina. This is a potentially life-threatening cellulitis of the floor of the mouth. Numerous spaces are involved in Ludwig's angina. For example, the submandibular space is affected and spreads from other spaces, such as the sublingual space and submental space. This affects the patient bilaterally and may also spread to the parapharyngeal neck spaces as well. It also may spread to the submaxillary space as cellulitis. It often involves the lower molars or pericornitis, partially erupted third molars. As one can see in this picture, the patient definitely has a pretty diffuse swelling involving the floor of the mouth and multiple spaces. Patients with Ludwig's angina may present with fever and malaise. The tongue may be displaced upwards and posteriorly, which can be noted while doing the clinical examination. These patients may also have difficulty swallowing and pain while swallowing. They also may have stridor or respiratory difficulty. The jaw opening may also be limited due to swelling and inflammation. %80 of the pathology is due to dental microbes, such as alpha hemolytic streptococci, staphylococci, and Bacteroides. This large swelling in Ludwig's angina spreads to the anterior cervical triangle to the clavicles, causing difficulty breathing, swallowing, and speaking. This may lead to asphyxiation as well as death. These patients may even need emergency procedures such as a tracheotomy or cricothyrotomy. Here's another image of a patient with Ludwig's angina. So what is the treatment for Ludwig's angina? Once again, these patients are usually seen in the hospital or an oral surgery setting. Treatment includes antibiotics such as penicillin. In addition, intraoral or external surgical drainage may be needed. And it is critical to monitor and secure the patient's airway at all times. Now we shall briefly discuss Lemierre syndrome. Lemierre syndrome is a rare, serious oral infection which needs intensive care unit treatment. It is caused by the pathogen Fusobacterium necrophorum, which may affect lung and brain tissue and lead to serious complications. As one can see from the images on this slide, this can lead to serious infection and complications. So how do clinicians diagnose and manage infections? As we all know, infection depends on the virulence of the pathogen, the number of organisms, as well as the host resistance. Pathogens need a port of entry into the body for an infection to occur. For example, through the skin, mucous membranes, apex of the tooth, saliva, etc. Tissue damage can then occur, and a mild infection may spread to become a serious cellulitis. Infections often spread through the path of least resistance. A chronic abscess may present as a draining sinus tract in some individuals. For example, a periapical infection tends to follow the thinner buccal plate bone into the vestibular space. Muscle attachments and the bony architecture may also affect the pathway of an infection. Veins in the head do not have valves, and therefore they cannot stop the backflow of blood, which can then cause a serious infection caused by dental pathogens to spread into the eye, sinuses, and brain. Also, one must remember that all the fascial spaces are continuous. As clinicians, we must do a thorough medical history and clinical exam, along with proper imaging tests and lab tests to properly diagnose and manage these infections. The patients may present with trismus, dysphagia, fever, abnormal vital signs, etc. So how do we manage the infection? Management of an infection includes removing the source of the infection, which often is a tooth. Antibiotics and pain medication need to be prescribed. In addition, surgical procedures such as a tooth extraction, cleaning, or debridement may definitely be needed. Incision and drainage may also be needed by cutting through the mucosa, exploring the tissue, and then placing a Penrose drain along with proper sutures. Clinicians need to really be careful about medically compromised patients. Oral infections pose a challenge for individuals with chronic diseases such as cancer, pneumonia, etc. Patients with compromised immune status, such as those with renal disease, alcoholism, geriatric patients, uncontrolled diabetics, drug abuse patients, those with HIV or on immunosuppressants such as steroids may also be much more prone to infections when compared to a normal, healthy adult. One must remember that in medically compromised patients, even a mild Candida mucositis can become a serious infection. Patients with infection must be followed up in a timely manner, possibly requiring multiple visits. Meticulous oral hygiene must be stressed, along with oral microbial rinses and/or medications. The prevention of the oral spread of infection. Early diagnosis and treatment is critical. Aseptic techniques are necessary. Proper sterilization, as well as prescribing the patient antimicrobial pre-rinses and post-rinses may also be very important. The use of the rubber dam as well as high volume suction definitely can help prevent the spread of an oral infection. Meticulous oral hygiene and flossing is necessary, and clinicians need to prescribe pre or post-operative antibiotics in a judicious manner. For example, penicillin with metronidazole may be quite effective in treating these infections. In addition, regular dental checkups, of course, are very helpful in the prevention of infection, as well as the use of triclosan, which is an antimicrobial agent. Clinicians should also be cautious and not administer local anesthesia through an area of a dental infection, since this could move pathogens to deeper tissues through needle tract contamination. It is recommended to change the needle if necessary. If one needs further clarification, please send an email to UTSD continuinged@uth.tmc.edu. This completes the course in dental infection, a lurking danger. It is time for you to take a short exam in order to complete the requirements for streaming video courses. Due to the nature of our subject content, a passing score of 90% is necessary in order for you to pass the course. Upon successful completion of this exam, you will be visually informed that you have met the requirements to proceed. If you fail to answer enough questions correctly, You will be instructed to retake the exam, and a new set of questions will be provided. You will have 3 chances to fulfill the requirements. If you are not successful, you will be instructed to retake this course again. Good luck and best wishes on the exam. Thank you.